This Thing Called Life is a podcast dedicated to exploring the twists, turns, and transformative moments that shape our lives and the lives of others. It is a space where we can share our experiences so we can learn, grow, and empower change. You're listening to This Thing Called Life. I am your host, Atlas. Today, our guest is Dr. Toby Campbell. Dr. Campbell is a cancer doctor with additional specialty training in palliative care. He is a practicing oncologist and researcher at the University of Wisconsin in Madison, a podcaster, a writer, and his academic work focuses on helping others develop skills for life's hardest conversations. Dr. Campbell talks about transforming conversations in healthcare, the power of language in patient communication, and his auditory documentary, Extraordinary Conversations, where you hear from the family members faced with the unimaginable, making a decision about organ donation in the wake of sudden loss. We start the conversation with Dr. Campbell describing what it was like as a fellow, taking part of the educational study that changed the course of his life.
Yeah, I was a participant in a study called OncoTalk. So this was at the time in around 2004. It was a study being run and led by a physician named Tony Bach, who is at the University of Washington. Tony was with colleagues running a study called OncoTalk, where they were recruiting oncology fellows and they were putting them through this educational paradigm that they had developed using simulation, practicing hard conversations in order to learn communication skills. For me, and the reason that I list it as a turning point, I have been someone who was always interested in conversations and in communication. But what that workshop did for me was place me into teach me something. Like, here's a strategy for breaking bad news, telling someone that they have pancreas cancer. Here's a framework that you might use to navigate that very difficult, life-altering conversation. But then the key thing was they dropped us into simulation and practice and paused live action along the way, allowing us to reflect on what I said and how that affected the conversation. And then we could actually rewind it and I could try different phrasing or a different question and then observe how the conversation changed because I changed the way that I expressed something. And that was the turning point in my life, that a conversation will evolve differently depending upon how the participants engage in it, what they say, how they interact. And now, just to say it out loud, it sounds patently obvious. Well, of course, the conversation will unfold differently. But that really was a turning point. I mean, that was opening of a Pandora's box for me that, well, how deep does this go? I mean, the phrasing of that question or that, I mean, we could change the phrasing of so many things, and how will that affect the conversation? And then my research career has been really around those kind of pivotal moments in conversations, those moments that really matter. When sometimes, I mean, I published a paper, just a single word substitution at a crucial moment in a conversation actually changes the way that that conversation unfolds. So it was a turning point because that has then actually been the hallmark of the rest of my career.
And it wasn't I mean, I know in this sense it was specifically for or tailored for oncology students and sort of delivering bad news. But it sounds like this technique and this way of communicating can be applied all across aspects of medicine, in family medicine. Also, in particular, I noticed like in research just how using these techniques in these ways of communicating with one another was helpful from doctor to doctor. I mean, it wasn't just doctor to patient; it was also doctor to doctor as well.
Absolutely. I think that um, skill in conversation is something that people can learn. And I think skill in conversation is, of course, something that applies to us in our work life, whether you are a doctor or a police officer or a teacher or a lawyer. I mean, I don't think it matters. All of us have conversations in our daily lives. And being skilled in those conversations will make you skilled at work, at your job. We have hard conversations in our regular life too. I think some of these strategies work in regular life, although many of the ones that I've studied, my wife will tell you work better at work than they do at home. But I think it applies everywhere. I mean, let's just think of an example. So imagine that you are a teacher. This just happened to me just, a few weeks ago. We had a parent teacher conference for my son. So imagine that you're a teacher approaching two parents and a child. This child is not doing as well as they could do, right? To the teacher, he's not living up to his potential. So she's entering into a difficult topic, right? Here's a father who's wearing a tie, and we're engaged. We're at the parent teacher conference, and she needs to tell us something that she doesn't know how we're going to receive it. She doesn't know us, but she probably guesses that this is gonna maybe surprise us or come up come to us in a way that we're not sort of excited about. And so that's a difficult conversation. And I would propose that that teacher or any teacher thinking about the way that they approach that particular conversation, observing, because teachers have I guess, the benefit or the burden of one after another, after another, after another. They could try different entries into that conversation. They could try different questions and they could observe how it unfolds differently. So I think this applies not just in all of medicine, but honestly in all of life.
Absolutely, a relationship with with friends and family. But I'm wondering, like, listening to you say there was like specific skills, or like I'm wondering if you have like examples of ways in which you learn to sort of deliver bad news. And um, I mean, I remember one of the quotes. It was the words that were used was like curiosity, and also like it made one of the physicians said it made the conversation more productive. And I'm wondering if you could speak to those two, and or how did they teach you to kind of go about delivering these bad news?
Sure. Oncotalk, that study that we talked about earlier, for breaking bad news, they use a mnemonic, a framework, really, and they call it spikes. It just stands for set the scene. If you're going to have a hard conversation, who needs to be there? Do I have all the stuff that I need? Do I have enough chairs, for example? Do I have Kleenex? The P is gain someone's perception. Really, what you want to do is understand, what does this person that I'm going to talk to already know? What are the words that they use to think about their cancer in this example? So that if those words are accurate, I could just use their words. The I is an invitation, essentially a request. Is it okay if we talk about? The K stands for knowledge or news. So is it okay that we talk about your CAT scan results, which show that you have pancreas cancer? So then I deliver the news. That E in Spike stands for respond empathically or respond to emotion. So then there's a sub module there where they teach you some phrases and ways to respond to emotion. Like, for example, naming it, just saying, I can see that this news is really upsetting, or, um, or exploring it more. Can you tell me more about how this feels? Importantly, using a feeling word, right? Can you tell me more how you're thinking about this? Could you tell me more how you're feeling about this? You'll get different answers. And that final S in Spike stands for summarize and strategize. Where have we come from? Where are we going? What's next? So they teach you spikes and then the empathic responses, and then you practice them and you learn how to get more skilled in that particular type of conversation.
I really like how it sets. I mean, it sort of it prepares physicians in a beautiful way. It's sort of like beginning, middle, and end. We're preparing stuff in the beginning. We're setting up chairs, making sure we have all the information, the middle, during the conversation, at the end, like how do we go forward? And the two things that came to my mind, and I love that that you all are doing this in teaching physicians to do this. Well, one, it sounds very trauma informed care. esque, putting control in having them be in control of things. Is it okay if we do this? Is it okay if we do that? And that sounds very trauma informed, and that's a fantastic thing. And the other part is reflecting content. That's a big use in counseling, is reflecting back to them to, one, it validates someone else's experience, but it's also showing that this person is attempting to understand. And if they're not, that's okay. Then they'll kind of correct you and like, no, it's actually feels more like this. So those are two things that I love, that's happening with these conversations. Do you feel like that this education, is it? I know is it being received well? Because I know maybe in the beginning it wasn't, because you had said that some physicians weren't really open to this idea. But yeah, I'm wondering, has it changed? Has this approach to medicine and communication and educating physicians on communication, has it grown? Has it changed?
I think perhaps there's a little bit more acknowledgement that these are skills someone could learn, but to be honest, I would say that change is a bit slow to come. I mean, any time you're trying to change people's behavior, you're going to face, an uphill climb. There will be some early adopters who will rapidly be interested and will take what you're telling them and what you're teaching them, and they'll go even past what you taught them, right? They're like me. When I first was exposed, like I've spent my whole career on it. So I'm an early adopter as far as that goes. There will be others who are like willing to go along with you during the day. They may change some things, they may not change that much. And then there will be others, honestly, who are not in a growth mindset about learning communication skills. They might say things like, I've been talking since I was 2, right? I think I'm pretty good at it. Um, and so you can't reach everyone. We did studies here, actually still doing our studies long term, over a decade, well over 1,000 physicians trained. And at all of our workshops, we asked people at the beginning and at the end how open you are to this type of training. And what's interesting for us in our data is that we have a 5-point scale. So if people say 0, meaning I'm not at all open to this type of training, after the workshop, they're highly likely to still be a 0. But if they say even 1, like I'm slightly open to this kind of training, our data shows almost everyone who was 1 or more ends up at a 5 or close to a 5, meaning they found it incredibly valuable. So if they were closed at the beginning, they stay that way and they derive no value from the training. If they were at least a little bit open, they will very often come away saying, that was way better than I thought it was going to be. It was actually helpful.
Do you see it being like incorporated in, or anytime soon, in some ways, um, like medical school and in the training, and or no?
Yeah, I mean, we do actually, I would say we've been more integrated in the past than we are now, but
Hmm.
um, medical education and medical curricula changes over time. There have been times where um, all of the medical students had access to some of the simulation-based training that we do here. At the present moment, not everyone. It's a subpopulation who kind of elects to do it, but that might change again in the future. I will say that medical school is certainly open and eager and interested in communication education, and that the leaders at the medical school recognize that that's important. The way in which we teach it has evolved over time, and med school curriculum in general, I would say, is going through a kind of a reimagining of itself right now. But I think that these, at the medical school level, I think these skills are recognized as being
Hmm.
important and relevant.
It sounds hopeful.
I'm,
Um,
I'm I stay hopeful.
and so the one thing that I did want to clarify for this is because I feel as though that it's palliative care, right? Can often can if you want to maybe real quick define what you would how you would define palliative care and how it's maybe different than hospice, because I know that maybe those two things can be a bit confusing.
Sure. Palliative care is a specialty relatively new in medicine, officially became a specialty in 2008. And we are really the people who you might call when you're facing something serious. If the people that you call when your heart is having trouble are the cardiologists, or the people that you call when you have a hernia are the surgeons. The people that you might call when you're facing something serious are the palliative care experts. Now, not everyone needs an expert in palliative care to help them. Sometimes they have everything they need with their other doctors that are already taking care of them. But we might be added to the case. We work with your other medical teams, whether that be heart doctors or surgeons or someone else. We're going to work with them and you to help you navigate the complexity of serious and life-threatening illness. Now, if that illness continues to progress and we reach a point where the medical system is really out of life prolonging options, or those options are so risky that the person has decided, I really want to try to maximize my time at home and minimize my exposure to burdensome treatments. And we're ready to talk about taking as the best care of someone that we can as they approach and reach the end of their life. That's really where hospice comes into play. Hospice is a service that's expertly delivered mostly to people who are outside the hospital. Palliative care is a support system that is mostly delivered to people who are still coming to the hospital or the clinics. So, a few ways of thinking about it, but hospice and palliative care are very closely related, right? We're trying to provide high quality care for people facing serious illness and facing end of life. Um, there certainly are some differences. One being hospital and clinic versus mostly at home, that kind of thing.
Okay. And what are some like services or things that people can receive from palliative care? I mean, I would imagine it includes like a host of people or social workers or therapists, nurses. I mean, what are some services that someone might receive in palliative care?
Ideally, we do work in teams. At my institution at the University of Wisconsin, we have those that you mentioned, physicians and nurse practitioner, nurses, social workers, chaplain. And we also partner closely with therapy and pharmacy and others, but those core members of the team. Not every health system is going to have uh, a, as robust of a palliative care program, but we try to deliver the care that someone needs in the moment that they need it. So if on a particular day they really need to see a physician or a nurse practitioner because their pain medications need to be changed, we want to do our best to make sure that that's who that person is seeing that day. If on a different day they're really feeling the existential weight of this serious illness and they're really contemplating life and what that means, and maybe their faith is important to them, and that's a part of this processing that they're doing. Maybe the chaplain is the best person for them to meet that day. Maybe there's a day where they're really thinking about advanced care planning and want to revisit their healthcare power of attorney, and so our social worker might be the best person for them to meet on that particular day. So we want to try to meet them where they're at to provide what they need on that particular day. And we have different team members who have different expertise and different roles, and hopefully we can get it all right where we meet them where they need to be met on that particular day.
I mean, I feel like palliative care sort of helps with all the pieces. I mean, something I've told with others is that like learning and growing and healing, it can be like this mosaic of all these pieces that need to be included, and it's not just one piece. And it sounds like for y'all, it's trying to get as many pieces of these together at once, so that someone can just go to one place or one space to kind of get everything taken care of. I wanted to shift things over real quick to the other turning point because after you went on this retreat, it was a sort of sudden realization that how impactful this communication can be, right? And if you just shift one word, one phrase, or one sentence, that you can have a completely different relationship and a completely different outcome. And so you learn this, and life goes on. But then it sounds like after you were at like a research conference with, I believe it was Atula Gawande. Am I pronouncing that right?
Yeah, Atul Gawande. He's a surgeon and author and researcher at Harvard, and he had invited me to give a presentation at his lab is called Ariadne Labs. Now he's stepped away from Ariadne Labs, but the lab still exists. It's just run by someone else. But this is in 2015 and 2016, and they had a research in progress presentation. So I got to go to Boston and present, and it was really cool for me because how often do you get invited to go to Boston. And Dr. Gawande has written 4 books, and I've read them all and was a fan, and I had all 4 of his books in my backpack. After I give my presentation, he gives me an hour, so we are talking to each other for an hour, and I remember pulling my books out of my backpack and saying, "Would you mind signing my books?" And he's like, "All of them?" And I was like, "Well, yeah, man, I don't know if I'm ever gonna see you again, so if you don't mind." So he signs my books, and then he's talking to me about the presentation that I had given, and at one point, he simply says the question, "Well, of course you know what it is, of course, that you do." And I remember saying, "Well, let's not assume that I know what I do. Why don't you tell me what you think it is that I do?" And he said, "Well, you're kind of an interesting person. You're a little bit more of a designer. You design conversations. You're a little bit more of a designer than you are a researcher, right?" I have a close colleague named Gretchen Schwarzy. He's like, "Dr. Schwarzy is really more of the scientist. You're the designer." And I honestly did not know that. That had not occurred to me until that moment, but it has changed how I think about what it is that I do since that conversation in 2015. I mean, I'm still working on that understanding of myself and what it is that I do. So it unlocked me, honestly, to think about myself as a designer, and that has been amazing, really fruitful.
I feel like it's shifted things. I mean, as a researcher, you're more thinking about data and analysis and how to collect data, how to collect the best data, and it's sort of like maybe it shifted more to like the context of I'm guiding these conversations. How can I improve these conversations? Is that the shift that happened?
Yeah, I mean, you're absolutely right. Like, to be a scientist is to be thinking about your methods. How are we going to study this? What data are we going to collect? How are we going to evaluate whether or not it works or doesn't work? As a designer, I'm thinking about a particular hard conversation. So I've done work. I'll do another simple example. So um, I did a big study, talk about science, did a big study. We looked at hundreds of transcripts of cancer doctors telling cancer patients bad news and that they need to think about different treatment because the current treatment isn't working. What was interesting in those transcripts is that in 4 instances of the 168 transcripts that we had, either a patient or a caregiver said, "Wait, what does that mean?" And we noticed that the conversations unfolded a little differently after the person asked that question. The oncologist seemed to be more fluid, seemed to be less filled with jargon, willing to
Mhm.
just say, like, "Whoa, it's bad news," something that was straightforward. So I hypothesized, what if since in 168 instances, patients only felt empowered to ask that question 4 times, what if we gave that question to the doctors? What if after telling a patient about your CAT scan results, you paused to ask a question? Would you like to talk about what that means? Like what it really means? And then I can tell you that patients almost always give you not just yes, but like a double yes, an emphatic yes. They'll say things like, "Yes, please. Yes,
Mhm.
I really wish you would. Yes, no one is telling me what's going on." These are the kinds of answers you get. And then what we've observed is that the conversations, like, they don't even resemble one another anymore. I mean, that just takes it in a different direction. The doctors become kind of genuinely warm and like free of all the jargon words. They say things like, "Well, I mean, it means it's not good. It means this cancer's more life threatening. It means it's really trying to kill you." They say things that are they're just very plain language. And patients demonstrate understanding. And like to your point earlier, it's also this very nice moment of giving control back to the patient. The patient could say no, right? "I don't actually want to talk about what it means." And sometimes they do, but they usually say, "Yes, please." So that's an example of a design element where I'm looking at data, looking at lots of conversations and asking myself, okay, so how could we make this conversation better in a way that matters, in a way that's meaningful, without kind of redesigning the whole thing, right? Without having to put doctors through hours of training. Well, gosh, what if you just put this one question in there and it actually works? So that's kind of the sort of study that I did after that conversation with a tool that kind of unlocked me to think about conversation in a different way.
It was sort of like the one question of it sort of like sends the message that these doctors genuinely want to them to understand. The other thing that came to my mind, which is interesting, I don't know if I'm accurate or not, is I feel as though that, these words or phrases that some of these doctors are sort of afraid to avoid, like killing, or those are actually the words that kind of are the ones that I don't want to say that they wanted to hear, but were more helpful. Doctors were using these jargons as a way to, one, it's the ones that they know and they're familiar with, but it was sort of like a way to shy away from these phrases that they were in some ways maybe afraid to use, and it turns out those were the ones that they preferred to use.
They make the most sense, right? Like I teach people to, when someone is dying, I teach people to use the word dying. I say you can use a different word in a particular situation, but I think the right word is the real word, is the word dying. So unless you have a good reason not to use it, I would encourage you to work towards using it. I'll give you a short story from a clinic just a couple of weeks ago. I had had a trainee in my clinic for 6 months, for a long time. And so they learn a lot of things in my clinic, how to take care of this type of cancer that I do, but also communication skills. And about halfway through the 6 months, this trainee said to me, my whole career, I've been trying to find a way to say things that didn't make people cry, that let them feel hopeful about the situation. I think you are saying things in a way that's like you're not shying away from that at all. You're just like going right at it and telling them what's going on, and they cry, and it actually works better. I, I've been trying to avoid this thing that now I've seen you do it, and it works better the way you do it. And I was like, yeah, I don't try to avoid it at all. Like, in fact, I don't really think I've done my job until I've seen them kind of take that information in, because it's terrible what I'm telling them. And unless they start to show me emotion afterwards, I kind of usually think I probably haven't reached them yet. I almost need to see tears or anger or frustration or some really strong emotion to know that I reached them. Yeah, I don't think you avoid it. So it was kind of like transformative for her.
And I mean, these are these are this is sad news. I mean, it is okay to have these emotional experiences. It is okay to cry. It is okay to be angry, and all these experiences are valid and they can happen. And I mean, I think we try to protect people from these experiences when those are healthy emotions to kind of go through. And it
Is
seems
there
like
is there a more appropriate time to cry?
right, absolutely, right, and like and with and in these spaces where there is help there. I mean, there are the physicians that are that have knowledge are there to kind of care and talk with him about things, but there's also social workers and therapists that are there, and I mean, it's if there's a place to kind of cry, it's sort of it can be within these hospitals, and I really appreciate the the shifting towards more sort of like I guess I'm going to call them like human words, meaning it seems like maybe doctors were using more of these sterile sort of scientific terms, but then shifting to more sort of human words that everyone sort of understands. It sort of changed things, and it changed the connection and the dynamic, and it allowed sort of patients and doctors to be present with one another.
I think so, right? In order for you and I to have a shared understanding of anything, right? We have to have that kind of dialogue. And I mean, I'm I think of this a bit philosophically, but and I'm pretty sure this is John Locke, not me, philosopher John Locke, who said, I package up words in my brain and I pass them through the neural mechanisms and I emit them as words. They're received by your ear, they're processed by your brain, and understanding blooms. But there are so many places where that communication can break down, right? And the understanding that blooms in your mind is not the one that I had tried to package into words and send. And one of the easiest ways it breaks down is we use words that people don't understand. And so knowledge doesn't bloom, understanding doesn't bloom, or um, it blooms in the incorrect way. I mean, there's an elegant study done by Jennifer Mack, who, pretty sure I got the author correct, who asked patients with colon cancer and lung cancer, "What's the point of your chemo? What's it trying to achieve?" And would you believe it? Almost 90% of these patients misunderstood the point of the chemotherapy that they were on. They thought that it was to try to cure their cancer, when in fact it wasn't. So if 9 out of 10 people can misunderstand the reason they're taking toxic medicine, that's, I think, gotta have to do with the understanding piece and the packaging of this knowledge, this information didn't get received in the right way.
Hmm. And and it changes. I would imagine it changes. How treatment is received and treatments. And like, I don't know if it would be like adherence to treatment. Would there would be better outcomes to treatment adherence when patients sort of understand what's going on, what's happening. And I mean, to your point of language, and we have to be using the same language to understand one another. I mean, if I was speaking Spanish, another language, it would be difficult for us to kind of understand one another. So that's sort of like a dramatic to sort of prove a point, and that the importance of using the language, the same language that the other person has. And do you kind of does that? I would imagine it's incorporated if people that are speaking a different language that there's like interpreters or there's physicians that do speak language that do come to kind of assist.
Yeah, interpreter services are a vital part of taking care of people whose language is different or who are using English as a second language and would prefer to understand something so complicated in their native language. And so nowadays, with either in-person interpreters or telephone or now often over the iPad, um, we should be able to meet the needs of any language. There are services available, and we should endeavor to do so. It, of course, takes longer to go through translation, but it's the right thing to do. People should hear terrible things in a language that they understand. I often try to talk to the interpreters ahead of time to let them know what's going to happen, um, because I find that they are not just language interpreters, but also cultural interpreters as well. And I've gotten absolutely invaluable advice from interpreter services who have said, well, in our culture, this might be important for you to know, and that might be important for you to know. And then I can conduct that visit in a more culturally sensitive way because I've been educated about something that's really important that I wouldn't have known. So I see the interpreters as colleagues and partners in these conversations. Um, I don't think all physicians consider them that way or treat them that way, but I think we should.
And I want to sort of transition over to, we're talking about conversations and the importance of communication in conversations, and you have a project or podcast called Extraordinary Conversations, correct? And I know the first season was about families and organ transplants and their experiences. And tell us a little bit about that.
Yeah, we made a documentary, it turns out. I didn't necessarily know what I was getting into when about 4 years ago when I started interviewing people who had made a decision to donate organs on behalf of their loved ones. And then I was interviewing people who did the surgeries, who took care of the patients after organ donation. Um, then we ended up going on 2 recovery trips, got to fly on small, medical jets to recover organs and bring them back to Madison, Wisconsin for the transplant. I met with people the day after they came off the breathing machine and having had received lung transplants. So we basically followed organs from the donation process all the way through to recipients living their lives with new organs in place. And then we told the story of what we learned. I interviewed approximately 50 people over the course of this project, had about 1,500 pages of transcripts of all the interviews once they were transcribed. And we created a documentary that tries to show people what organ donation and transplantation, what's going on. It turns out there are a number of extraordinary conversations. The one that I started with is that truly amazing one where someone goes to meet with a family in an ICU, a family in crisis on a day they thought would never happen, right? Someone that they love is brain dead after some kind of terrible injury. And they are in a position of being asked if they think their loved one, their person, would want to donate their organs. So that's an extraordinary conversation because there's no other conversation like it in medicine. If normally you're asking someone about surgery, that surgery is intended to benefit them. Now, might not happen, might be side effects or whatever, but it's intended to benefit them. The organ donation surgery is not. It's intended to benefit someone else. And so that makes it a one-off, extraordinary conversation. And so that was actually what led me to want to dive into this particular project. But then I'm not an organ donation person. I don't work in transplant. So I kind of come to this as with an outsider's perspective. But I was really taken aback and stunned by the depth of commitment and care and concern that really everyone from beginning to end shows to both donors and donor families, to recipients. It's just a sort of an extraordinary medical practice. I was touched, especially. I mean, I think everybody thinks about the recipients, those that get hearts and lungs and go on and live their lives. But I was really touched by the attention, the care, the concern that they show for donors and donor families. And so we wanted to tell the story of what we learned. So anyone who's curious about organ donation, anyone who's curious about organ transplant or has someone in their life who's received a transplant or was a donor, I think would have something to learn about what it's like to work in this field, what it's like to be a part of that.
I mean, if you're just a human being, I think you should listen to. I mean, the idea. I mean, so when I hear transplant, you kind of hear like it's a friend or family member, and it's sort of planned, so to speak. There's a list, but you don't kind of think about these scenarios, the one that you just had described, when someone's in a situation where they're brain dead and they're no longer going to live, and there's a decision that needs to be made, and we have X amount of time to be able to take whatever organ it is, and so the family has to make a decision in a certain amount of time. And I mean, let's say that is it is remarkable. I think what um, humans are doing remarkable things, and I feel like you're capturing it. I think in particular, I know in the news, and I mean, there's all these terrible things, and these terrible things need to be acknowledged and reported. But I also feel like there are wonderful, amazing things that human beings are doing, and one of them is these donors.
I think you're absolutely right. Um, I was also struck that the families of the donors, at least the ones that I talked to, all of them, it affected how they lived the rest of their life. The fact that there was this legacy piece mattered to them. So we think about the recipients, we think about the donors, but the donor families were changed, of course, by this horrible experience. All the donor families that I talked to, it was an unexpected brain injury, an unexpected event, not at all planned for, that happened, and then their loved one was brain dead. Um, but they moved forward in life, whether they were in contact with the recipients or not. Some of the donors we talked to, donor families we talked to, were in contact with people who had received organs, some were not. They all, I think, were changed by that experience, for all the ones that I talked to, in a positive way.
Mhm. And it can seem, I mean, I know I talk about a lot about spirituality with people, and it seems in a lot of ways that this could be, I mean, a turning point for a lot of people and a lot of families, and it could be like a spiritual experience, being able to let go, and but also um to let the sort of legacy live on, and into someone else, and to benefit another human being. Um and it seems like you all capture the beginning, but also the end, when the individual receives the organs. That's correct?
Yeah, we covered it, tried to follow those organs all the way through, just to let listeners know kind of what happens. One of the topics that we took on was the rituals and social elements of dying in this particular way, which is not a normal way. I mean, organ donation in the 50s and 60s was science fiction. In the 70s and 80s was a fringe kind of treatment. Really became something that is actually real and happening in the 90s and 2000s. And now is kind of an established practice, and people are learning to manage the immune system and rejection in ways that are allowing them to even back off a little bit on rejection medications, so that people even face less risks after transplant now. So it's gone from science fiction to mainstream medicine over the course of a lifetime. And I would say our social norms have not caught up to what it's like to know a family who's waiting for their loved one to donate organs, because it takes a small number of days from the time that someone has decided, yes, I think my loved one would be an organ donor, and yes, let's try for it. And from that moment until the moment when the surgery happens to recover the organs can be a small number of days. And so we actually paid a lot of attention to what happens in those few days, because it's different than what other normal experiences are like for dying. And so yeah, we wanted to talk about that.
And what do people have to look forward to, in because I would imagine there's season 2, correct?
Well, good question. I mean, I'm still processing because it
Season
did.
1
I said four
I'm still
years,
processing the one episode that you just described to me, so
and I'm not kidding. It took me 4 years to finish that project. It was
uh-huh.
much bigger. So I think for me, I loved making it, and I love listening to it, and I love the reactions that we're getting from people who've listened to it. So it was a project that was well worth doing. Um, I think there is a season two of a documentary style, but I think again it's going to take me a while because I interview the way I do it is interview lots of people, and I'm a doctor. I'm a cancer doctor. I got this is like totally a side gig, so like figuring out when to do all of that is a lot of after hour stuff, and so it takes a while. Um, I have contemplated ways of doing a season, like an interspersed season two, more like this, where I'm interviewing someone about extraordinary conversations that we can turn just kind of a conversation into an episode so that we can keep some of the momentum going without having to completely pause while we put together, the second documentary. But I do think that that's a commitment. Maybe right here and right now is the one that I'm going to make. Maybe I'm making it to myself and all of your listeners. Yeah, I do want to do a season two. It did take me a minute to pause because it was a lot of work. I'm not going to lie to you.
I mean, it sounds like it's worth doing for so many reasons. I mean, it really taps into, the importance of communication, you know what I mean? And emotions when I mean, specifically when you're talking about organ donation and the communication between families and doctors and the emotions, that are, and obviously involved, in it, and, yeah, so I hope there's a season 2. The last thing I wanted to give you an opportunity to chat about is I know there's, a book that is on the way, that it's in the process. Tell us a little bit more about this book.
Yeah, I'm on a book contract, so I owe my publisher, Post Hill Press, 60 to 80,000 words this August. It's coming along pretty good. I've never written a book before. It turns out that is also a real big project. Um, and to get a nonfiction book contract, you have to send in a pretty detailed plan. What's the book about? What map out your chapters. I had written 2 sample chapters. So the book, the scaffold, the skeleton of the book was already, quite well established. So now all it is a matter of writing all the chapters. But so I'm just marching through. My editor and I are helping me. Um, and yeah, so the book is called something like A Doctor's Guide to Hard Conversations. And very intentionally, it's about not just medical conversations, but rather what are the skills that we bring to conversation across industry, across professional specialty, teachers and lawyers, and as we were talking about earlier, just what are those kind of fundamental skills that we bring to conversation that are important for everyone to know about. And in the book, I use a metaphor of a house. So if you picture a house as a kind of a conversation, it has structure. Let's just say it's a bad news conversation. Well, this house has a porch, right? And I'm going to go tell someone that they have pancreas cancer. Well, I can't just open up the door myself, barge in, walk right to the kitchen where, we're going to have a kitchen table conversation. I can't just walk in and tell them that. I mean, I got to get into the house. So the metaphor of the house helps me realize, like, well, I need to have a little bit of entryway talk, right? So that I can even get into this conversation. And then I got to find my way to the kitchen and ask them if it's okay if I sit down and we talk about this. So our houses have sort of component parts. Like the kitchen is a part of every house, but it also changes how I get there, right? So picture yourself touring a house with, you're a realtor, you're touring a house with a young couple who loves to entertain. So you enter the house, you go right to the kitchen and show them the kitchen. But a little later that day, you're touring the house with a young single guy who is an outdoorsman. So you actually enter the house through the garage and show them that there's space to keep all of their toys in the garage before you enter the house. And a little later that day, you're touring a family through and you make sure to pause at the back door where there's cubbies for the backpacks and the shoes and all those things and show them the backyard where there's room for play structure. So, this very same conversation, we might enter and approach in different ways depending upon who we're talking to. And the same is true with conversations. There's a kitchen in many of my conversations, which is the meat and potatoes of what I need to tell them. There's a room where we read and respond to emotion. There's, of course, the entry and the exit, right? How do I get into this conversation? And very importantly, how do I leave it? You know, what does that look like? I picture myself when I'm in, say, for example, the room in the house where I'm eliciting values. I picture myself as standing in a room with someone, looking around and saying, well, tell me about that picture on the wall. Who are those people? Like, why do they matter to you? Tell me about that piano that's in the corner. Is the piano something that's important to you? You're an artist, you play piano, So I just picture myself gathering information about what's important to them, their values and goals, by imagining that I'm in a physical space. And so I think about conversations, and this metaphor rolls throughout the whole book. Each conversation is a different conversation house, and we point out some of the rooms and some of the skills that are the same, whether you're a teacher or a doctor. But teachers have their own unique conversations, and the framework is a little different. So we try to go through um, how to be an expert in a variety of different conversations, but more to sort of the point that we made at the beginning, like it's really about the design and the structure. And I trust that the readers will be able to, once understanding that, will be able to put their own expertise into their specific conversation. But I hope that the book helps them do it with a little bit more elegance and expertise.
And there's two things. I mean, it's wonderful. And the two things that are coming to my mind is, and I know is one of your values was curiosity, and also creativity. So yeah, it's very creative, sort of using this house as an analogy. But it also, what was coming to my mind is it sort of puts the physician in the space of I don't know, meaning it assumes that this doctor does not know anything about them, does not know like where they're at. It just puts them in a doctor of, hey, I don't know. How can I know? What are some ways I can, what are some phrases or words to kind of get to know them? And so I really like that for a lot of reasons. One, like I said, it's a place of curiosity. And when we're curious about things, we sort of don't know. We don't, we don't know where they're at. We don't know how they're going to respond. We don't know this and that. And I think that's a healthy approach to things. The last thing is, how can listeners support you?
Well, I think for me right now, um, listening and sharing extraordinary conversations. You can find it at extraordinaryconversationspodcast.com or Apple or Spotify or I'm told wherever you listen to podcasts. I don't have it on YouTube. I know people upload a lot of stuff to YouTube. Maybe I should figure that out. But right now it's on Apple and Spotify. And I think, gosh, give a listen. What I usually tell people is listen to the first 5 minutes of any of the episodes. That'll give you a really clear sense of what we have, because it isn't a conversation like this one. It's very much a documentary. And the episodes kind of are standalone, and they're titled based on who we're talking to that day, whether it's the donor families or the recipients of hearts and lungs. And you can drop in on episode 5 and then go back and listen to one. It doesn't really matter. So give a listen to 5 minutes and see if you want to keep listening to the rest of the episode, and then share it. I think the point of the podcast is to talk about organ donation and transplantation, but bigger than that, to talk about hard conversations and how they can be approached with skill, and how that makes a really big difference for everyone involved with whatever that conversation was about. And I think that translates to everyone.
You can listen to Extraordinary Conversations and Dr. Campbell's podcast, Palliatively Speaking, on Spotify and Apple Podcasts. Dr. Campbell is currently writing his book, A Doctor's Guide to Hard Conversations. If you enjoyed this episode, you can support the show by liking, sharing, or subscribing wherever you're listening. You can find us online at thisthingcalledlife.center. If you'd like to be a guest on the show, visit thisthingcalledlife.center/contact. Until next time, thank you for listening and being with us on This Thing Called Life.